implantation. Don't forget that the blastocyst implants in the uterus about what day? 6 and 10. And then high yield beta HCG secretion begins. So in the vignette, if they say, what is the first hormone that can be detected in the blood after 6 to 10 days of fertilization? What's the answer? Beta HCG. Remember the caveat, it can be found in the blood after 6 to 7 days, 6 to 7 days after fertilization, beta HCG. Next, gastrulation. So you have the inner cell mass, right? Your embryoblast, it becomes a bilaminar disc. Now, this one, the bilaminar disc, it is separated by a basement membrane. It becomes another 2 parts. You have the epiblast, and then you have the hypoblast. We're going to talk about these in the next couple of slides. So gastrulation just means the formation of bilaminar disc. So most of the germ layers come from where? From your epiblast. So you have your ectoderm, endoderm, and your mesoderm. Don't forget, epiblast, all the germ layers come from there. Your ectoderm, your endoderm, and your mesoderm. Don't forget from term 1, examples of each. Example of mesoderm. Anyone? Where can we find mesoderm? Hello?
Adrenal cortex.
Mesoderm can be found anything that has a mesenchyme, right? You have your muscles, right? How about endoderm? Endoderm is like the lining of organs, the lining of your urinary system, the lining of your GI system. How about ectoderm? It's 2 parts. You have surface ectoderm, right? And you have the neural ectoderm or your neuroectoderm, okay? Don't forget the adult derivatives of each. Next, embryonic period. The first 8 weeks after fertilization, this is where organogenesis occur. High yield, this is the period that is most vulnerable to what? Teratogens. After the embryonic period, you have the fetal period, where the organs and the structures grow. Heart development during the embryonic period. So week 4, don't forget, the heart begins beating. How can I remember week 4? You have 4 chambers of the heart, right? 4 chambers of the heart. Think week 4, the heart begins beating. And week 6, transvaginal ultrasound, it detects fetal heart movement. Week 10, another thing is happening, right? Prior to week 10, before week 10, the genitalia, they look similar for males and females. However, at week 10, you can now identify the gender, okay? How do I remember week 10? Genitalia sounds like tenitalia. So, genitalia week 10, okay? Next, let's talk about the gland itself. So we have the pituitary gland, anterior versus posterior pituitary. The anterior pituitary, also called adenohypophysis, this is from where? Rathke's pouch of your ectoderm. The posterior pituitary, or the neurohypophysis, is from your neural tube. The adrenal gland, don't forget the cortex and the medulla, they're different embryological origins. The cortex is from the mesoderm. What are the hormones secreted in the cortex? Aldosterone, cortisol, androgens. We're going to go over that in the previous, the next slides. Medulla, you have the neural crest cells. It secretes epinephrine and norepinephrine. These are your catecholamines. How about, let's talk about teratogens. Teratogens are drugs. Sometimes these are substances of abuse like alcohol, cocaine, smoking, radiation, sometimes chemicals, sometimes maternal illness. If the mother has diabetes, if the mother has PKU, and also don't forget high yield, the torch infections. I think this is a DLA. So toxoplasmosis, other diseases, rubella, CMV, and herpes. We're going to go over each of them. So seizure drugs, if the mother has epilepsy, right, it may require drugs in pregnancy. However, be careful. anti-seizure drugs, they may affect the fetus. What's the effect of the fetus? Neural tube defects. Don't forget, anti-seizure drugs, it will gonna induce neural tube defects in the fetus. Example of anti-seizure drugs, phenytoin, carbamazepine, gabapentin, all of those drugs. It can also induce congenital heart disease, cleft palate, short fingers, and abnormal facial features. But when I say seizure drugs, you say neural tube defects. So fetal hydantoin syndrome, this is associated with your phenytoin use in pregnancy. You can have growth deficiency, you can have abnormal facial features, specifically microcephaly, and cleft lip and cleft palate. This is used in seizure disorders, okay? Think phenytoin, growth deficiency, specifically what? Microcephaly, right? And then you can have cleft lip plus cleft palate. Isotretinoin, this is your derivative of your vitamin A. This is used to treat acne. What's the pregnancy class? Class X. It can induce spontaneous abortions. So in the fetus, you can have abnormal facial features, you can have congenital heart disease, and hydrocephalus. Tell your patients that birth control is mandatory when the patient is having this drug. Okay, birth control is mandatory if the patient is using isotretinoin for cystic acne. Methotrexate. Methotrexate, it inhibits your folate metabolism. Let's go back to term 1. What does it inhibit? Purine or pyrimidine synthesis? For methotrexate. Anyone?
Purine?
So actually it is the pyrimidine synthesis. Remember, what enzyme does it inhibit?
We don't remember.
You don't remember? Okay. Don't forget, at the end of term 2, you have the BSCE exam, which is an exam that tests your knowledge during all of the first year material from med school. Please don't forget. So pyrimidine synthesis, dihydrofolate reductase. It converts your tetrahydrofolate and it converts your dihydrofolate to tetrahydrofolate. For what? For the use of your thymidylate synthase. Remember, from DUMP to DTMP. And don't forget the drug that inhibits thymidylate synthase, your 5-fluorouracil. Okay, purine and pyrimidine synthesis, don't forget. So methotrexate, it inhibits folate metabolism, pregnancy class X. When I say methotrexate, you say neural tube defects. Okay. Thalidomide. Thalidomide. This is also a pregnancy class X. It is used for treatment of multiple myeloma. The bad thing is it's used in the 50s as sedative in pregnancy. What's wrong with thalidomide? Anyone can remember? Thalidomide.
FGF gene?
So for thalidomide, why does it induce limb deformities? Let's talk about biochemistry. Remember, it's a racemic mixture. So if it's a racemic mixture, it has both amounts of enantiomers, right? It has S and R.
Yeah, that's right. And one of them's bad.
Exactly.
I remember
Exactly. Excellent. So don't forget that it's a racemic mixture, right? You have 2 equal amounts of enantiomers, right? So this induces limb deformities in the 50s. So you can have amelia, absence of limb. How can I remember amelia? A, absence without, right? Micromelia, short limbs. Micro meaning short, right? Focomelia, abnormal limb. Okay. When I say thalidomide, you say limb deformities. Okay. Don't forget the terms, the 3 terms. Amelia, absence. Micromelia, short. Focomelia, abnormal. Next, diethylstilbestrol, a non-steroidal estrogen. It is used to prevent miscarriage or premature birth. You have a slightly increased risk of breast cancer for mothers. However, high yield point here is this. For female babies, you can have reproductive tract abnormalities. Question, what is so controversial about diethylstilbestrol exposure in mothers. There is actually a research that's going on here. Anyone? What's so controversial about DES? So if if you don't know, one of the research says that this one, it actually, for mothers who are exposed to diethylstilbestrol, it increases the risk of the fetus for gender. So for homosexuality, right? And bisexuality. That's the controversial thing here. However, recent evidence shows that it's not true. Okay? Next, alcohol, high yield. Look at the features, right? Fetal alcohol syndrome. Look at the characteristics on the lower right side. You have a small eye opening, you have a smooth philtrum, and then you have a thin upper lip. In the vignette, they're going to describe you the facial features, right? And the answer is fetal alcohol syndrome. Small eye openings, smooth philtrum, and thin upper lip. What's worse than a mother who's drunk? A mother who smokes, a pregnant mother who smokes. So smoking, if the mother smokes, you can have a low birth weight, right? You can have placental anomalies. You can have abruption. You can have a previa. So you can have premature rupture of the membranes. And smoking also induces preterm labor. And what's the high yield point here? For smoking, it has an association with sudden infant death syndrome, or SIDS. When I say smoking, you say low birth weight and sudden infant death syndrome, or SIDS. What's worse than a pregnant mother who drank alcohol, who smokes? A pregnant mother who uses cocaine. Remember cocaine? It induces vasoconstriction. Let's go back to term 1. What is the mechanism of action of cocaine? Anyone? Mechanism of action of cocaine?
It's numbing, right?
From term 1, remember the norepinephrine? What does it do? It inhibits reuptake, right? It inhibits reuptake of your norepinephrine. And did you go over the synthesis of your catecholamines or not yet?
We did.
Not yet? Okay, maybe in the next module. So when I say cocaine, you say vasoconstriction.
And dopamine.
Yes, yes. Yes, because remember your catecholamine synthesis from phenylalanine to tyrosine, tyrosine to L-DOPA, L-DOPA to dopamine, dopamine to norepinephrine, norepinephrine to epinephrine. When I say cocaine, you say vasoconstriction. What does it do with the fetus? Low birth weight, you can have preterm birth, and you can have miscarriage. Next, maternal diabetes. So what happens to the baby if the mother has uncontrolled diabetes mellitus? So the baby is large, macrosomia. So the baby is born large for gestational age. Usually the weight is more than 90th percentile. The baby's often is more than 9 pounds at birth. Let's talk about the physiology of maternal diabetes. So the mother has uncontrolled diabetes, increase in glucose. Question, can the glucose cross the placental barrier? Yes, right? So it can cross the placenta to the fetus. What happens now to the pancreas of the fetus? Think about it.
Increased production of insulin would be there.
Exactly. So it increases production of the insulin. So what hypertrophies in the pancreas? Is it the alpha cell, beta cell, or delta cell?
Beta cells.
Beta cell, because the beta cell increases insulin, right? So you have hypertrophy of this baby. So what happens after birth? What can you expect now? After birth, the high level of glucose is gone. So what can you expect in the fetus? Oh, I'm sorry, in the baby. After birth,
They'll still have a high amount of insulin though, right? So could they go
exactly
into like
what happens.
coma or something like that.
So you can have transient hypoglycemia. Okay, don't forget that one. You are now removing the high glucose. But remember, the glucose crossed over the placenta to the baby. The baby has now hypertrophy of the pancreas. So the beta cells are producing more and more insulin. And now after birth, the high glucose is gone, but the baby is still producing high amounts of insulin. So you can expect the baby to have transient hypoglycemia. Another thing, when I say maternal diabetes, you say macrosomia, large baby, which can lead to what? Birth injury. Don't forget, it can induce shoulder dystocia. The shoulders cannot pass through the birth canal. Let's go back to term 1. What is that injury that you can have? Shoulder dystocia. The shoulders cannot pass through the birth canal. What injury is it? Herbs or Klumpke? Anyone?
I don't remember this one.
Herbs. Excellent.
Herbs.
It's the upper trunk, guys. So please, when you're studying for this, remember to integrate materials. Always integrate, always integrate. Okay? We're going to help you in the long run. Now, let's go. Testes, right? How does the baby become a male? You need to have an SRY gene. SRY gene from the Y chromosome. What does this gene codes for? It codes for what? Testis determining factor. This testis determining factor. It forms Sertoli and Leydig cells. Don't forget, Leydig cells produce testosterone. Testosterone is used for male development, specifically the male secondary sexual characteristics. Okay? How about the ovary? The ovary, you have the medullary cord regresses, the cortical cords develop, they form clusters. The ovary is surrounded by your germ cells. Here you can have the oogonia and follicular cells. They form primordial follicles in your ovary. And we're going to talk about the meiosis of your oocyte later. How about the genital ducts? The genital ducts are two pairs of genital ducts in the embryo. You have the mesonephric duct or the Wolffian duct, paramesonephric duct or Mullerian duct. Don't forget, remember the terms, okay? Remember mesonephric and paramesonephric. Let's go back to term 1. What is mesonephros? Mesonephros, what is it? Remember the origin of your kidney? What is the primordial kidney called? Okay, guys, pronephros, right? Remember the pronephros? That's the first part of your kidney. Then it involutes, right? I don't care about your pronephros, right? And then you have the mesonephros. What's high-yield here? Your tubes comes from this one, the mesonephric duct. And then you have the metanephros, right? The metanephros, you have the metanephric blastema. This is the embryological origin of your nephron, specifically the glomerulus up to the distal convoluting tubule. Don't forget to integrate materials, okay? So mesonephros, interim kidney first trimester, associated duct, mesonephric duct. Paramesonephric duct, it is formed near mesonephric duct. When I say mesonephric or Wolffian duct, you say male duct system. When I say paramesonephric or Mullerian duct, you say female duct system. So let's talk about the genital ducts. In the male, don't forget high yield Sertoli cells. The Sertoli cells, they secrete Mullerian inhibitory factor. What is the function of the Mullerian inhibitory factor? It suppresses the development of your paramesonephric duct. So this makes sure that you are male, right? The Mullerian inhibitory factor, it makes sure that you develop the mesonephric duct to develop male characteristics. The Leydig cells, they secrete androgens. Don't forget that the Leydig cells, they stimulate the development of your mesonephric duct. When I say Sertoli cells, you say Mullerian inhibitory factor. What's the function of the Mullerian inhibitory factor? Suppresses the development of para-mesonephric duct. When I say Leydig cells, you say androgens. What's the function of androgens? You say stimulates the development of your mesonephric duct. Now let's talk about the females. How about in the females, you have the para-mesonephric ducts. They form the internal structures. They only occur in what? Absence of Mullerian inhibitory factor and androgens. What are the adult derivatives of the para-mesonephric ducts? Your fallopian tubes, uterus, and the upper 2/3 of your vagina. Para-mesonephric duct, think about internal female structures. Fallopian tubes, uterus, upper 2/3 of the vagina. It only occurs in the absence of the Mullerian inhibitory factor secreted by the Sertoli cells and androgens secreted by the Leydig cells. Now let's talk about some pathology. Uterine anomalies. The most common, septate uterus. Think about septum, septate. So a septum that divides the uterus. What's the defect here? Resorption of septum between the Mullerian ducts. Okay. Septate uterus. What's the embryological defect? High yield. Defect in resorption of septum between the Mullerian ducts. How about bicornuate? Bicornuate, you have an indented fundus of your uterus. What's the embryological defect? High yield. Partial fusion of the Mullerian duct. Unicornuate. Uni means one, so the uterus is connected to one ovary. So the other ovary is not connected to your uterus. How about uterine didelphys? You have a double uterus. What's the high yield embryological defect here? The Mullerian ducts fail to fuse, or failure of fusion of your Mullerian ducts. Next, another high yield point, put a star here, external genitalia. Know the embryological origin and the adult derivatives. Genital tubercle, it elongates. This becomes the phallus. Urogenital folds becomes the penile urethra. Urogenital sinus becomes the glands, specifically the prostate gland and the bulbourethral glands of Cowper. And the labio-scrotal swelling becomes the scrotum. Know the embryological origin and know the adult derivatives. How about hypospadias? Hypospadias. This is congenital anomaly of your male urethra. Where is the opening? Dorsal or ventral? Ventral opening of the urethra. What's the embryological defect? High yield, failure of urethral folds to close. Sometimes this accompanies cryptorchidism or undescended testes in 10% of patients. Hypospadias, ventral opening of urethra, failure of urethral folds to close, commonly associated with what? Cryptorchidism or undescended testes. Contrast that with epispadias. Epispadias, where is the opening? Dorsal side of the penis. What is the embryological defect? Abnormal formation of the genital tubercle. This is commonly associated with what? Bladder exstrophy. Epispadias, urethral opening on the dorsal side of the penis. Embryological defect, abnormal position formation of genital tubercle, commonly associated with bladder exstrophy. So don't forget, compare and contrast hypospadias with epispadias. Next, the development of male external genitalia. It requires what? Dihydrotestosterone. Don't forget, testosterone can be converted to dihydrotestosterone by what enzyme? High yield 5-alpha reductase. So what if you have 5-alpha reductase deficiency? What happens? You can have ambiguous genitalia until you have puberty. At puberty, you have an increase in testosterone and you can have your development of male secondary sexual characteristics. What's high yield? testosterone to DHT. What's the enzyme that converts it? 5-alpha reductase. What if I have a deficiency in 5-alpha reductase? Ambiguous genitalia. Until when? Until puberty. Why do we have development of male secondary sexual characteristics after puberty? Because you have an increase in testosterone. How about in female? Another high yield point. Know the embryological origin and know the adult derivatives. The genital tubercle, it becomes the clitoris. Urogenital folds, labia minora. Urogenital sinus, the glands, specifically paraurethral glands, your skin, and Bartholin glands. The labioscrotal swelling, labia majora. Remember, the development of your external genitalia requires estrogen. Let's talk about meiosis now. This is just a review from term 1. I have a question. What in the cell cycle, where can we find DNA synthesis? At what phase can we find DNA synthesis? Is it G1, S, G2, or M?
S phase, right?
Exactly. So DNA synthesis is in the S phase. And you have meiosis 1 and meiosis 2. What's the purpose of meiosis? Development of your 4 haploid cells. And meiosis is exclusively for your gametes, right? Only for your gametes. Now let's talk about this. Spermatogenesis. First, you have spermatogonium. Spermatogonium, it undergoes mitosis to form the primary spermatocyte. So the primary spermatocytes, during this phase, the DNA synthesis is completed. You are starting meiosis 1. So you undergo meiosis 1 and you form secondary spermatocytes. After the formation of secondary spermatocytes, you do another round of meiosis, meiosis 2, to form your spermatids. And then you have the process of spermiogenesis to form your spermatozoa. So let's go over this again. Spermatogonium, it undergoes mitosis to produce what? Primary spermatocytes. How many rounds of meiosis do you need in order to get a spermatid? You need 2 rounds of meiosis. So from primary spermatocytes, you have meiosis 1 to get secondary spermatocytes. From secondary spermatocytes to spermatid, you need another round of meiosis, which is meiosis 2. And do you need something else after production of spermatids to produce a mature spermatozoa? Yes. What do you call that process? We call that spermiogenesis. Don't forget that the spermatids, they are now haploid, right? What do I mean by spermiogenesis? This is the formation of your spermatozoa or sperm. To make them mature, you add the acrosomal cap, you add the flagella to make a mature sperm, and we call that process spermiogenesis. Now, how are we going to support this sperm? So you have cells in your body called Sertoli cells. They line the walls of seminiferous tubules. They support and nourish your developing spermatozoa. What's the function of Sertoli cells? Sertoli, it begins with S. Think spermatogenesis, right? Sertoli, spermatogenesis. What stimulates Sertoli cells? FSH. There's S in there in Sertoli. There's S in FSH. It is supported by Leydig cells, which secretes testosterone. It needs FSH and LH for normal spermatogenesis. So when I say Sertoli, you say spermatogenesis. It begins with S. Sertoli has S. And it is stimulated by what hormone? FSH. There's S there, right? There's also S in Sertoli. Okay? What other things that the Sertoli cells have? They form the blood-testis barrier. What is the significance of the blood-testis barrier? Actually, it's a tight junction between your adjacent Sertoli cells. It isolates the sperm. It protects the sperm from autoimmune attack. Now, give me a pathology that reduces the blood-testis barrier that you know. So mumps, actually, mumps or orchitis, did you talk about this one in class or not yet?
Briefly.
So the mumps or orchitis, it actually attacks the virus, it attacks your Sertoli cells. So it reduces your blood testis barrier. Remember, your sperm, your sperm, they are foreign to the body. You're going to learn this in term 3. That's why it needs to be isolated, right? They don't have any antigen in them. They need to be protected from any kinds of attack. So you need to have the blood testis barrier. So when I say Sertoli cells, you say spermatogenesis, you say regulated by FSH, and you say blood testis barrier. Now this is like a cross section of your seminiferous tubules. Here you can see your Sertoli cells, right? They are around your developing spermatids. Where are the Leydig cells? Are they inside the tubule? No, they are outside the tubule, actually. The Leydig cells are your interstitial cells. They are between your seminiferous tubules. What is inside the tubule? Sertoli cells and the developing sperm. What is outside the seminiferous tubule? You have the Leydig, your interstitial cells. Now let's talk about oogenesis. This is high yield. So you have the primary oocyte. They are the diploid cells formed in utero. They are arrested in what? Prophase of meiosis 1. Primary oocyte arrested in what? Prophase of meiosis 1. Then what happens at puberty? Menstrual cycles begin. A few primary oocytes, they complete meiosis 1 each cycle, and they form secondary oocytes. The secondary oocytes, however, are arrested in what phase? Metaphase of meiosis 2. High yield. Primary oocyte is arrested in what? Prophase of meiosis 1. The secondary oocyte is arrested in what? Metaphase of meiosis 2. What happens if there's no fertilization? The oocyte degenerates. But if there is fertilization, you have a completion of your meiosis 2, and then you form the ovum. Let's talk about the decidual reaction. In the endometrium, what happens? The reaction of the endometrium at implantation. So you talk about the decidua. Decidua is the lining of your uterus during pregnancy. 3 parts, high yield. Decidua basalis, the basal layer, don't forget. This is the site of implantation. This is the part of your endometrium that interacts with trophoblast. The decidua capsularis, it surrounds the fetus. Decidua parietalis, found in the opposite wall of the uterus. What's high yield here? Decidua basalis. This is the site of implantation, and this interacts with trophoblast. How about the membranes? What's the difference between amnion and chorion, high yield? The amnion, this is the inner membrane that covers the fetus. It holds the amniotic fluid. So when you do genetics testing like amniocentesis, this is the part that you're going to get the fluid, the amnion. What's the function of the amniotic fluid? It protects the embryo. How about the chorion? The chorion is a membrane that surrounds the embryo or your amnion. It is derived from what? High yield trophoblast. What's the function of the chorion? It supports the fetus and amnion. When I say amnion, amniotic fluid, protection of the embryo. When I say chorion, trophoblast, supports the fetus. So what is this trophoblast? So the trophoblast actually it proliferates into 2 layers, syncytial trophoblast and cytotrophoblast. Syncytial trophoblast is the outer layer. What's the function of the syncytial trophoblast? It invades the endometrium. It has finger-like projections like your villi. It forms lacunae for your maternal blood. The cytotrophoblast, on the other hand, is the inner layer. It secretes proteolytic enzymes to aid in the invasion of your decidua. And the chorionic villi are the projections of your both layers. This is the one that has a contact with the maternal blood. What's the function of a chorionic villi? For nutrient gas exchange. Summarize, trophoblast, it develops into 2 layers. What are they? Syncytial trophoblast, outer layer. What's the function? Invades endometrium. It projects villi It forms lacuna or spaces for your maternal blood. There's an inner layer. What is that? Cytotrophoblast. It proliferates. It aids in cell migration into the syncytial trophoblast. What does it do? It secretes proteolytic enzymes to aid in the invasion of your decidua. What do you call the projection of both layers? We call that chorionic villi. This is the one that has a contact with your maternal blood. What's the function of the chorionic villi? Nutrient and gas exchange. Placental circulation, high yield point here is this. The umbilical arteries, they carry deoxygenated blood. The umbilical vein carries oxygenated blood. Let's go back to term 1. In the fetus, there are ways. There are 3, what do they call this one? Shunts that have in the fetus. So can you remember the shunts? 1, the blood shunting away from the liver. What do you call that? Ductus venosum, right? Your ductus venosum, don't forget. What is that? Ductus venosum, hello? Are you all there? Yeah. So the ductus venosum, it becomes your ligamentum venosum. There's another one. What is it? Another shunt, foramen ovale, right? The foramen ovale, it becomes what? Fossa ovalis in the adult, right? And then the last one, the last shunt is your ductus arteriosus. The ductus arteriosus, it connects what to what?
That's in the aorta.
Aorta with what? Pulmonary artery, right? That's your ductus arteriosus. And you have a condition called patent ductus arteriosus. What is the characteristic murmur in someone who has PDA? What is the characteristic murmur that you can hear? Let's go back to term 1.
Machine-like?
Exactly, machine-like murmur. You have a continuous machine-like murmur. What is the drug that you're gonna give to close the PDA? I know it's in there. I know you know this. It's
like aspirin.
Indomethacin or an NSAID to close it. What keeps it to keep it open? If someone has an atrial septal defect, you need the PDA to be open, right? Or else the baby will have cyanosis. So what are you going to give in order to keep the PDA open? Prostaglandin E1 and E2. It keeps the PDA open. Don't forget that one from term 1. So umbilical arteries, deoxygenated blood. Umbilical vein, oxygenated blood, okay, from the fetal side. That's high yield. There is a barrier. We call this the placental barrier. What's the function of a placental barrier? The function is there's no mixing of maternal and fetal blood. So in this barrier, the oxygen and the carbon dioxide, they just diffuse. As I've said, the glucose is transported. Here, you have the facilitated transport of glucose. You also have active transport of your amino acids. What is the only antibody that crosses the placenta? It's IgG. IgG is the only antibody that's going to cross the placenta. You're going to learn this in term 3 when you get immunology. Some other nutrients also can cross, some drugs and some infectious agents. When I say placental barrier, you say no mixing, no bueno of maternal and fetal blood. What only crosses? Oxygen, carbon dioxide. How about glucose? Yes. Via what mechanism? facilitated transport. When I say facilitated transport, you say there's a protein that needs to be there in order to transport glucose. Amino acids. What's the mechanism? How does it cross the placenta? Active transport. When I say active transport, you say ATP is involved. What is the only antibody that crosses the placenta? You say IgG. Also, some other nutrients cross, some drugs and infectious agents. The umbilical cord. What's the significance of the umbilical cord? So it connects between the embryo and your placenta. This one is derived from the fetus. It contains your umbilical arteries and your umbilical veins. The yolk sac is a cavity that is formed in early embryogenesis. The allantois is an outpouching of hindgut. Next module, you're going to learn about the allantois. So let's go back to term 1. What is the umbilical cord? Is made up of what kind of substance?
Wharton's jelly.
Wharton's jelly, which is composed of what? Remember glycosaminoglycans, right? Your GAGs, glycosaminoglycans, to make it more pliable, okay? Put this allantois at the back of your mind. Next module, you're gonna talk about the different pathologies regarding the allantois. So as I've said, in the umbilical cord, look at the image, high yield image. You have 2 umbilical arteries. Don't forget, the arteries, they carry deoxygenated fetal blood to the placenta. And you have only 1 umbilical vein. The umbilical vein, it carries oxygenated fetal blood. Without this, how do you know? By looking at the image, without looking at the answers, right? How do you know that it's an artery and it's a vein? How do you know? Just looking at the image.
Muscle.
The
Don't
muscular.
look at the identifier. Excellent. So your artery is much more thicker, right? Remember your what do you call that layer in the artery? Let's go back to term 1. That layer.
Tunica media.
Excellent. Tunica media. You have 3 layers, right? From the arteries. So remember, integrate materials. Tunica intima, which surrounds the lumen. Tunica media, the muscular layer. And then you have the tunica adventitia. Excellent. So you have a much thicker media. Look at the image here. You have a much thicker media in the arteries than the vein. So the vein is usually collapsible. What is unique in veins that cannot be found in arteries?
Valves.
Excellent, excellent. So you have valves in your veins. So don't forget the characteristics from term 1, the difference between the arteries and the veins. Now let's talk about ectopic pregnancy. Ectopic pregnancy is pregnancy outside the uterus, high yield. Where does it occur? In fallopian tube. Specifically, where in the fallopian tube? Most commonly the ampulla, okay? When I say ectopic pregnancy, you say commonly occurs in ampulla of the fallopian tube. Oligohydramnios. What do I mean by oligohydramnios? Anyone?
Less. Little.
Oligohydramnios is less due to what? High yield fetal renal abnormalities due to bilateral renal agenesis or posterior urethral valves in the males. Sometimes it causes placental insufficiency like preeclampsia or maternal vascular diseases, and it can also cause premature rupture of membranes. Contrast that one with polyhydramnios. You have more amniotic fluid. This is due to what? High yield fetal swallowing malformations, specifically esophageal, duodenal atresia. Remember from term 1 TAF, your tracheoesophageal fistula, and also anencephaly. Don't forget also maternal diabetes, fetal hyperglycemia, which can cause polyuria. Question: maternal diabetes is commonly associated with what congenital defect in a child? Let's go back to term 1. Maternal diabetes is commonly associated with what congenital defect? Anyone that can remember?
Trisomy?
Come again?
Trisomy?
Trisomy. Think about heart defects. Think about the cyanotic heart defects. They begin with T. Don't forget transposition of the great vessels. So when I say maternal diabetes, think about transposition of the great vessels. When I say rubella, think about patent ductus arteriosus. Let's review those, okay? So fetal anemia also, it can lead to high fetal cardiac output. You have an increased urine production. It can occur in parvovirus infection. We're going to learn in term 3 about parvovirus B19, which can cause aplastic anemia. And also, don't forget, multiple gestations can cause polyhydramnios because you have more fetal urine. So high yield point, compare and contrast oligohydramnios from polyhydramnios. Oligohydramnios, less amniotic fluid due to what? Basically, bilateral renal oogenesis. Polyhydramnios, more amniotic fluid, usually due to what? Esophageal or duodenal atresia. Okay. Now, hypertension in pregnancy. Hypertension means you have an elevated blood pressure. So it can either be pre-existing or chronic, or gestational. So gestational hypertension, we're talking about elevated blood pressure that develops after 20th weeks of pregnancy. We call this one preeclampsia. How do I know if someone has preeclampsia? You can have hypertension in pregnancy. What else? You can have proteinuria. Now, question, what's the difference between preeclampsia and eclampsia in terms of the presentation of the patient?
Eclampsia is more severe. It's like they're bleeding more or something like that.
So eclampsia is much more severe, right? But what gives it away in the vignette? Because you can have hypertension, you can have proteinuria. What gives it away? Neurological symptoms, specifically seizures. If you see in the vignette hypertension, proteinuria, and then there's seizure there, it is eclampsia, okay? That's the difference between preeclampsia and eclampsia. Eclampsia, you have an additional symptom of seizures. Excellent. Term 4, you're going to learn about how to manage eclampsia and preeclampsia. Placenta previa. Placenta previa, this is causing painless bleeding during pregnancy. Contrast placenta previa to placental abruption or abruptio placenta. So here, placenta previa, think about the abnormal implantation, right, of the placenta. Look at the image here on the lower right. So the placenta is where? Up to the os, right? Up to the opening of the cervix. So the delivery will be difficult, right? It causes painless bleeding during pregnancy. That's high yield, painless bleeding. Contrast this one with abruptio placenta or placental abruption, where you can have painful bleeding. For placenta previa, it may require C-section. What are the risk factors? Prior placenta previa, multiple pregnancies, but high yield, prior C-section. You can have placenta previa. Management and pathophysiology, you're gonna learn it in term 4. Different abnormal attachment. So you have placenta accreta, placenta increta, placenta percreta. Are these high yield? Yes, I've seen UWorld questions. Placenta accreta, the placenta is attached to where? Myometrium. Let's do an anatomy first of your uterus. You have the endometrium, right, which is the basal layer, the decidua, and then you have the myometrium. This is the muscle layer, right, and the innermost layer is you have the serosa, right. So the decidua is much closer to the lumen of your uterus. So accreta, the placenta is attached to where? Myometrium. Placenta increta, it penetrates the myometrium, and placenta percreta, It invades the uterine serosa, or the outer layer. But the high yield point here, I think, is the placenta previous and the placenta accreta, the placenta attached to the myometrium. No penetration into the myometrium. Management and pathophysiology, you're going to learn in term 4. But please make sure you know the terms and the definition of each abnormal attachment of the placenta. Torch infections. This will be elaborated more next term in term 3. Let's go over each one of them. Toxoplasma gondii, toxoplasmosis, classic tried in fetus hydrocephalus, high-yield chorioretinitis. When you see chorioretinitis in the vignette, think Toxoplasma gondii. And then you can have intracranial calcifications. So what are you going to advise the mom to avoid having toxoplasmosis?
Cleaning a cat litter box.
Exactly. Tell them to avoid cleaning the cat litter box. Congenital syphilis, right? The mother has a syphilis infection. So signs and symptoms in the fetus, maculopapular rash, and something with the nose, runny nose. So the two high yield points. When I say congenital syphilis, say maculopapular rash and runny nose. BZV, varicella zoster virus. What is this? This is herpes 3, HHV3, caused by your herpes HHV3 virus. What are the signs and symptoms? In a newborn, you have scars, microcephaly, hydrocephalus, and seizures, but high yield point, long term. The baby can have mental retardation. I don't like that word. I don't like retardation. So think about intellectual disability. Okay? So when I say varicella zoster virus, you say long-term effect is intellectual disability or learning disabilities. Parvovirus B19, parvovirus B19, hydrops fetalis. What is this? A fluid accumulation in the fetus. This is due to what? It's an immune condition from Rh mismatch. So this condition, you're going to learn more in term 3. Okay, so parvovirus B19, think about aplastic anemia, think about hydrops fetalis. What is this one? Fluid accumulation in the fetus, commonly from what condition? From Rh mismatch. Did you talk about Rh mismatch or not yet?
Yes.
Briefly.
Okay, Rh negative mother, Rh positive fetus. First pregnancy. This is the first pregnancy. Can the baby develop hydrops fetalis? Yes or no?
No,
Why?
because the mother didn't develop the antibody.
Excellent. Now, second pregnancy of the same mother. Can it develop hydrops fetalis? Yes, right? So what are you going to give to the mother? To reduce the risk of developing hydrops fetalis to the fetus, what are you going to give the mom? Don't
Some
forget
RH factor, right?
Don't forget ROGAM, RHOGAM, ROGAM. What method? IM, IV, SC, subcutaneous. What method? Intramuscular, IM. So you're gonna give IM ROGAM to the mother. So don't forget, only the second pregnancy can develop hydrops fetalis. The firstborn, it's okay. So rubella. When I say rubella, you think patent ductus arteriosus, you think cataracts. They love that in the vignette. When you hear cataracts and consistent, persistent machine-like murmur, that describes PDA. Think rubella. And they also love this, this term, blueberry muffin baby, right? So you have blue rashes all around the baby. So when I say congenital rubella syndrome, you say sensory neural deafness, cataracts, patent ductus arteriosus, and blueberry muffin baby. CMV, cytomegalovirus. When I say CMV, you say sensory neural hearing loss. What's the difference between conductive hearing loss and sensory neural hearing loss?
Isn't one mechanical and the other one is neuronal?
Exactly. So sensory neural hearing loss, there's something wrong with your cochlea. Remember your cochlear membranes? There's something wrong there. Contrast this one with your conductive hearing loss. There's blocking maybe your middle ear or your outer ear. So when I say CMV, you say sensory neural hearing loss. Now we have some cervical neoplasia from the cervix of the mom. So you have epithelial neoplasia. It occurs in what? Squamocolumnar junction. What is this? Squamocolumnar junction. Don't forget that your cervix has two parts, the endocervix and the ectocervix. The endocervix is columnar epithelium. The ectocervix is squamous epithelium. That's why we call that junction squamocolumnar junction. Or another name for that is a transformation zone. What infection predisposes you to a cervical neoplasia? A, CMV, B, HPV, C, VZV, D, parvovirus B19.
HPV. B.
HPV. What kinds of HPV? 3 and 8 or 16 and 18?
16 and 18.
Excellent. 16 and 18. 3 and 8, you can have your condyloma acuminata, your warts, your varicose warts. Excellent. And do we have a vaccine for that?
Yes.
Yes, we now have, thankfully, we now have vaccines for that one. Don't forget, herpes is forever, right? It lurks into your ganglion, so it never goes away in your body. So let's talk about this one. This is high yield endometrium. 2 cycles. You have the ovarian cycle, and you have the menstrual cycle. So what is happening? So let's look at the ovarian cycle. In the ovarian cycle, you have an increase in FSH. Look at the blue line here. FSH is increase. Why does the FSH increase during the follicular phase of the ovarian cycle? What's the purpose of the increase in FSH?
Stimulate the release of the oocyte from the follicular cell.
So you want the oocyte to mature, right?
Yeah.
So that's why you have an increase in your follicular stimulating hormone. So you want the oocyte to mature. What causes the rupture of that mature oocyte or ovulation? What causes ovulation? High yield LH surge. Look at the LH surge. It causes ovulation at what date? Day 14 specifically. And then look at the proliferative phase, right? Or the luteal phase of the ovarian cycle. What hormone is predominant now in the luteal phase of the ovarian cycle?
Progesterone.
Progesterone and LH, right? Don't forget your LH. So in the ovarian cycle, follicular phase FSH, luteal phase LH. What causes ovulation? Day 14, LH surge. What is happening now? Let's correlate what's happening in the ovarian cycle with the menstrual cycle, with what's happening in the endometrium, right? So first, you have the proliferative phase. So what's happening here in the follicular or the proliferative phase?
Spiral arteries are branching out and building up along with the glands.
Excellent. So the uterus is anticipating a pregnancy. So it's the formation of the spongy layer and then the compact layer, and then afterwards you have the progestinal or the secretory phase where you have glands. You can have now the spiral arteries. Okay. Now let's look at the ovarian follicle. So this is an egg, a picture of an egg surrounded by cells. High yield 2 key cells, theca and granulosa cells. Theca cells stimulated by LH, granulosa cells stimulated by FSH. Theca cells, LH, granulosa cells, FSH. Let's go about penis anatomy. So this is like anatomy. You have the foreskin, the glans, the corona. You have the corpus spongiosum and the corpora cavernosa. You have the urethra in where? In your corpus spongiosum, right? Okay, here. What's high yield here? So remember your corpora cavernosa. They are enclosed by what? Tunica albugenia. So your corpora cavernosa, there's two of them. They're enclosed by tunica albugenia. Another high yield point. The corpora cavernosa plus the corpus spongiosum. It is enclosed by what? The buccal fascia. Those are your high yield points. Another high yield point, your deep dorsal vein and superficial dorsal vein. This is high yield for what? For your erection or tumescence, right? What else? So physiology, right? Flaccid penis, you have decreased inflow of blood. How does erection occur? Erection occurs, or tumescence, it occurs via smooth muscle relaxation. You have increase in blood flow. So what happens? The corpora swells. Your corpora cavernosa or corpus spongiosum, they swell, they compress the veins, which decreases the outflow. High yield, your Viagra, your sildenafil, your vardenafil, tadalafil, they all end in afil, right? So these are your phosphodiesterase 5 inhibitors. What's the function? Phosphodiesterase, they break down cyclic GMP. So these drugs, they inhibit the breakdown of cyclic GMP, which increases cyclic GMP, which increases nitric oxide. Okay, let's summarize. Phosphodiesterase 5 inhibitors, they inhibit the breakdown of cyclic GMP, which increases cyclic GMP, which increases nitric oxide. Okay, therefore you have a relaxation. The muscles, the smooth muscle cells. Now this one, this is high yield. Another high yield is varicocele. So varicocele, what do I mean by varicocele? This is scrotal pain and swelling. You have dilated veins. You have the bag of worms appearance. All right. So varicocele, look at the image here on the upper right. So you can see the left scrotum. It's enlarged compared to the right scrotum, right? So the left one you have, it kind of looks like a bag of worms, right? So you have a more swelling with a Valsalva maneuver or standing. This is diagnosed by ultrasound. So what if I have a varicocele, you ask? It can cause infertility because it increases the temperature of your scrotum, and it can have you can have necrosis, ischemia, due to poor blood flow. When I say varicocele, you say bag of worms diagnosed by ultrasound. So what if I have this one? It can cause infertility. Contrast this one with hydrocele. Hydrocele. What's the embryological defect of hydrocele? Anyone?
The there's the vagin. Oh God, I forgot this one now.
I think it's a patent tunica vaginalis.
Excellent.
That's it.
Mm-hmm. Failure of the processus vaginalis to obliterate or to close. How do you differentiate hydrocele from varicocele in terms of physical exam?
Transillumination.
Exactly, transillumination. Where can you see transillumination?
Endoscrotum.
What condition can you have positive transillumination?
Hydrocele.
Only in hydrocele, right? Remember here in varicocele, you have veins. The veins are just dilated. In hydrocele, due to the persistence of your tunica vaginalis, right, you have a fluid accumulation. So when you shine a light, you can clearly see the fluid, okay? Cryptorchidism, undescended testes. When I say cryptorchidism, you say low sperm count, and you say infertility, right? So you have an increased risk of germ cell tumors. Of course, you're gonna learn this more in term 4. You can also have inguinal hernias or testicular torsion, but think about low sperm count and increased risk of infertility or cryptorchidism. How are we going to treat cryptorchidism? How are we going to treat?
Removal.
Surgical?
You can do surgery, right? So you can do surgery. Should you cut one ball or both balls?
One. If it's only
I
one.
think both because they're more prone for like cancer and stuff.
Excellent, excellent. Both of them. Okay, so you're gonna learn this in term 4. You're actually gonna cut both of them because of risk of germ cell tumors. You have an increased risk. So if you cannot correct it surgically, you cannot pull it down to the scrotum, then you need to cut them both.
What if it's only one that's undescended? Then you just cut one, right?
Because of the risk of germ cell tumor, you actually have to cut them both.
Now, my brother had only
Okay.
one that was undescended, and they left it in him when he was a baby. They left the one that was descended. They left it in him, and now he has a child of his own. My beautiful little nephew.
Okay, that's a good. But does he has an increased risk of any germ cell tumors afterwards, or no?
I guess they didn't tell him he was only a baby when he had the surgery.
Oh, okay. So probably if it's corrected early, right?
Maybe.
Because
isn't the risk because the testes are in the human body, so there's an increase of the temperature, so it causes. So if it's outside the human cavity, it wouldn't cause a problem, right?
Yep, you're right. It's in the abdominal cavity, so it's not yet descended. Okay. No. So that's your cryptorchidism. If it's earlier caught, then yes. But if it's later, there's if it's caught at a later stage, problem not a baby, then you need to cut them both. Prostate. So prostate, round gland, base of the bladder. It's anterior to rectum. So you palpate it on your digital rectal exam. It encircles the urethra. It produces your prostatic fluid and stimulated by your androgens. BPH, high yield hyperplasia of stromal and epithelial cells results in what? Complete urinary obstruction, not a premalignant condition. What zone does undergo hyperplasia in BPH? What zone of the prostate?
Periurethral.
Periurethral zone, right? Contrast this one with what? Prostate adenocarcinoma. Prostate adenocarcinoma, it starts with P. Therefore, you have what zone? Peripheral zone starts with P. What lobe starts with P? Posterior lobe. Okay? Prostate adenocarcinoma, peripheral zone, posterior lobe. Now let's look at the thyroid. Anatomy, you have 2 lobes, left and the right. You have an isthmus, a thin band of tissue between the lobes, and you have some pyramidal lobes above the isthmus. What's high yield here? Embryology. So it descends into the neck. Question, what's the remnant in the tongue? What do you call the remnant in the tongue of this thyroid, of your thyroid? So the thyroid actually, it goes down, right? Via a duct to its final place. Okay, what do you call that remnant of that duct in the tongue?
Is the central groove?
Or your foramen cecum, right? So you have your foramen cecum in your tongue. It maintains a connection to the tongue. So we call this one thyroglossal duct. I think you're gonna learn what module is that? The difference between anterior cervical neck mass versus a thyroglossal duct cyst. Does anyone know the difference between a thyroglossal duct cyst and anterior cervical neck mass? What's the difference in clinical presentation?
The thyroglossal duct moves when swallowing.
Excellent. The thyroglossal duct. This is the only one that moves with swallowing. The anterior cervical mass, it doesn't move. Why? Remember, what's the problem there? In your anterior cervical neck mass, what's the problem? Persistent cervical sinus. That's the problem. Here, you have persistence of your thyroglossal duct. Don't forget, the thyroglossal duct, it should disappear later in the development. And we have the remnants, we call that foramen cecum in your tongue. We talk about thyroglossal duct cyst, midline neck mass. It is painless. It classically moves up with swallowing or tongue protrusion. Thyroid histology. Look at the gland. It contains follicles. It is filled with your colloid, a proteinaceous material. So each follicle, you have a single layer of epithelial cells that line each follicle, and we call that one follicular cells. So the follicular cells are the ones that synthesize now hormone. So a thyroid gland, you have follicles. What is in each follicle? They are lined by single layer of epithelial cells. What do we call these cells? We call this follicular cells. What do? They synthesize the hormone. High yield thyroid peroxidase, TPO. What is the function of thyroid peroxidase?
Coupling, oxidation.
Mm-hmm. So it adds iodine, right? So you have you can have oxidation of your iodine, right? And then pairing them with your tyrosine. So you need thyroid peroxidase. Most of your anti-thyroid medications act against this enzyme, against your thyroid peroxidase. Another one, thyroid peroxidase also for iodinification, right? Putting iodine into your thyrine. So what's the function of thyroid peroxidase? As I've said, oxidation of iodide, right? So three functions. Primero, oxidation of iodide. Segundo, organification of iodine into MIT or DIT. Tercero, coupling of MIT DIT into T3 and T4. Don't forget that antibodies to your thyroid peroxidase are most common in autoimmune thyroid disease. For example, your Graves' disease and your Hashimoto's thyroiditis. You're going to learn more, term 4. Thyroid hormones. Which one is more potent, T3 or T4?
T3.
T3 is much more potent. Don't forget that one. What converts T4 to T3?
It's on the slide.
Prime.
Yeah, that's on the slide.
The iodinate, right? It converts T4 to T3. Most conversion occurs in your peripheral tissues. So you're going to learn more in term 4 about the peripheral conversion. That's why you give beta blockers here. So thyroid hormone, right? Which is more potent? T3. What converts T4 to T3? 5' deiodinase. Where does this conversion commonly occur? It occurs mostly in the peripheral tissues. Excellent. What are the effects then of your thyroid hormone? Increased carbohydrate metabolism. So think about catabolism, right? Catabolism. Think about increased carbohydrate metabolism. You have increased fat metabolism, increased lipolysis, right? You have increased cholesterol secretion in the bile, increased LDL lipoprotein receptors in the liver. Okay, for hypothyroid patients, you have increased cholesterol. For hyperthyroid patients, you can have hyperglycemia. Another metabolic effects, increased BMR. How does thyroid increases BMR? High yield increase in sodium, potassium, ATPase pump. If you have a more pump, more ATP is consumed, If you have more ATP, you have increased oxygen demand to replenish that ATP. You have increased respiratory rate. Remember, oxygen is the final electron acceptor of your electron transport chain. And you have an increase in body temperature. Hyperthyroid patient, they have weight loss. Effects of thyroid on CNS and the bone. High-yield childhood hypothyroidism. You can have cretinism. When I say cretinism, you say stunted growth and intellectual disability. Most common cause of cretinism in the other parts of the world, iodine deficiency. That's the
isn't cretinism untreated though?
Like
it's usually caught nowadays, right? But it's untreated, it turns into cretinism, right?
So this is if you don't have any iodine in the diet, you can have cretinism, or right. If the thyroid doesn't develop, or if you have any inborn errors of your hormone synthesis, or you don't have thyroxine TPO. Okay, so, but the most common, I've seen questions from UWorld, the most common cause of cretinism actually is iodine deficiency. If you have deficiency of iodine in the diet, but there are a lot of causes, but the primary thing is this one, iodine deficiency in other parts of the world. In America, it's TPO. So read the vignette carefully. If it says most common cause of cretinism outside of the US, in other parts of the world, it is iodine deficiency. But if it says in the US, it's antibodies against TPO, or thyroxine peroxidase. Okay. How do we regulate your thyroid hormone? So your T3, T4, they are sensed by your hypothalamus. So the hypothalamus secretes what? TRH, thyrotropin releasing hormone, which stimulates your anterior pituitary or posterior pituitary. Anterior pituitary to produce what? Thyroid stimulating hormone. And then you have T3 and T4. The increase in T3 and T4 will gonna provide a negative feedback mechanism to your anterior pituitary and to your hypothalamus to decrease production of your TRH and TSH. Calcitonin. Calcitonin, another hormone, it lowers serum calcium. Think for calcitonin, it opposes the action of your PTH, or the parathyroid hormone. So calcitonin, it lowers serum calcium. It has a minor role in calcium handling in humans, used as pharmacologic therapy for your hypercalcemia. Graves' disease, high yield. Graves' disease, commonly seen in hyperthyroidism. What are the signs and symptoms for this one? You should know this. Exophthalmos, bulging eyes. So you have periorbital edema. What causes exophthalmos?
The formation of glycoproteins behind the eye.
Specifically, you have an increased glycosaminoglycans, your GAGs, behind your eye. That's why you have protrusion or proptosis and periorbital edema. You can also have pretibial mixed edema, only on the shins. You can also have T-cell lymphocyte activation of your fibroblast. And of course, stimulation leads to secretion of your GAGs, your glycosaminoglycans, which draws in water. That's why you can have swelling in your exophthalmos. When you give hyperthyroid medications, which is the only one that cannot be resolved? When you give antithyroid medication, for example, levothyroxine, out of these signs and symptoms, which is the only one that cannot be resolved?
Exophthalmos.
Why? Due to the mechanism of action, right? So levothyroxine, actually, it can reduce mixed edema. It can also reduce the expression of your TSH receptor, but it cannot help you with your exophthalmos, because this is what? This is hypersecretion of your glycosaminoglycans. So that's why you give beta blocker for this. We're going to learn more in term 4. So iodine deficiency. Look at the woman here. right? So you have goiter. This is goiter. You have constant elevation of your TSH from your anterior pituitary. There is no feedback mechanism. That's why you can have enlarged thyroid. Most common in what? In mountainous areas. Think about, there's no iodine, right? Iodine depleted for goiter. Adrenal glands, you can find this above the kidneys. Arteries, of course, suprarenal arteries. Veins, you can have that one question. Which is longer, left renal vein or the right renal vein? A longer route of the blood.
Left.
Why?
Because they go through the renal vein, go through the renal vein, then to the IVC.
Yes, excellent. So what is that? Have you heard about Nutcracker syndrome? Not yet. Nutcracker syndrome? Not yet?
Not yet.
Okay, so probably that's for next module. But never mind. So cortex and the medulla. Cortex, 3 groups of hormones. Yeah, mineralocorticoids, glucocorticoids, androgens derived from mesoderm, epinephrine, and norepinephrine. Sympathetic nervous system control. So the medulla is stimulated by the postganglionics. By what neurotransmitter of the postsynaptic ganglion? The adrenal medulla is stimulated by what neurotransmitter of the postsynaptic ganglion?
ACH.
Okay, acetylcholine and norepinephrine. Oh, which is which? Let's go back to term 1. Anyone? A review?
ACH.
So acetylcholine, okay? Acetylcholine for your medulla. It's post-ganglionic. Don't forget that. When I say mineralocorticoids, think aldosterone. Aldosterone. Where is this? This is from your renin-angiotensin-aldosterone system. Let's go back to term 1. What causes increase in renin?
Loss in blood volume.
So loss in blood volume, what else?
Increase in serum concentrate.
Low GFR.
Decrease in your serum concentration, right? So this induces the macula densa to say, hey, juxtaglomerular apparatus, please increase renin. We have a low blood volume, we have low blood serum osmolarity. So renin is increase. Renin converts what to what? Angiotensinogen.
No.
Angiotensin 1. Angiotensinogen. Excellent, excellent. Angiotensinogen is produced by what organ?
The liver.
Liver.
The liver. Angiotensin 1 is converted to angiotensin 2 by what enzyme?
ACE.
It's the ACE1 in lungs.
Angiotensin 2, it induces the production of your aldosterone. Where does it act on the nephron? The aldosterone.
DCT.
DCT, excellent. Distal convoluted tubule. What does it do in the DCT?
V2 receptors and increase in aquaporins.
Actually, that's for your
oh no, yeah, that's ADH. Yeah, sorry.
It actually increases reabsorption of your sodium.
Sodium, right? Yeah, sodium. Sorry.
And the water follows. Excellent, excellent. So if I have increased sodium reabsorption, what happens to potassium?
It decreases.
So you have increased wasting of your potassium. So you increase reabsorption of your sodium in the distal collecting tubule, which also increases water reabsorption. Remember, the water follows the salt, right? And this mechanism, you have potassium wasting. You are now excreting your K plus into the urine. And that's just a review from term 1 of your renin-angiotensin-aldosterone mechanism. How about cortisol? Cortisol, glucocorticoid, right? It is synthesized by your cortex. So this hormone, they translocate to the nucleus. Why? Why can cortisol translocate to the nucleus? Is it like
steroid hormone?
Hydrophilic, hydrophobic? What is it?
Lipophilic.
Lipophilic, excellent. So it just traverses your membrane, your cell membrane, your phospholipid bilayer, right? It just goes there. It just enters the cell. How does your cortisol increases expression of your protein inside the cell? Remember from term 1, what is that mechanism?
Camp?
I heard it. What is it? CREB. Excellent. Yes, CREB. The CRE and the CREB, right? To increase the formation of your mRNA, right? So it binds to your DNA, increases mRNA production, then increases protein, okay? To increases more of the production of your cortisol. So remember, it's an intracellular receptor, right? Cortisol, like your estrogen, like your progesterone, they are intracellular. They can just go into the cell. Contrast this one with insulin and glucagon. What are they? What kind of receptors do they act on?
The protein insulin acts on tyrosine. Oh.
So tyrosine kinase, exactly.
And glucose is CCAMP. Right.
Exactly. Excellent. Excellent. So your tyrosine kinase. Do you know any non-tyrosine kinase stimulators? What's the difference between tyrosine kinase versus non-tyrosine kinase? This is a review from term 1. What's the difference? Which one is JAK-STAT? Tyrosine kinase. Tyrosine kinase has your JAK-STAT mechanism, right? You have intrinsic phosphorylation of your tyrosine kinase. Contrast this one with your non-tyrosine kinase, which you don't have intrinsic phosphorylation. Example are cytokines. You're going to learn more in term 3. So we're just doing review, okay? So we talked about aldosterone, renin-angiotensin aldosterone, mineralocorticoids, and we talked about cortisol, which is a glucocorticoid, which translocates to the nucleus, which activates or suppresses gene transcription. Now let's talk about the pituitary-adrenal axis. In the hypothalamus, it produces what? Cortisol releasing, corticotropin releasing hormone, right? And then it induces the pituitary gland, specifically the anterior pituitary, to secrete what? ACTH. ACTH, it goes to your adrenal gland. And it stimulates your adrenal gland to secrete what? Glucocorticoids. If I have more glucocorticoids, what happens? Negative feedback. Always think about negative feedback. To where? To the pituitary gland. To what? To decrease production of ACTH. And to where? To the hypothalamus. For what? To decrease production of your CRH. So the high yield point here is this. If I have a downstream, if I have an increase in my downstream, what do they call this one? It's not material. Downstream hormones, right? For example, if I have an increase in glucocorticoids, it produces a negative feedback mechanism to both the hypothalamus and the pituitary gland. Okay, that's the point. Increase in glucocorticoids, negative feedback, decrease ACTH, decrease in CRH. Cortisol, well, there are different effects of cortisol. You need to know them. High yield maintains blood pressure, right? So because of increase in cortisol, you can have hypertension and Cushing's. Decrease in cortisol, you can have hypotension in adrenal insufficiency. Cortisol suppresses immune system. Via what mechanism? How does it suppress the immune system?
By reducing your T and B cells?
Yes, it reduces T and B cells by specifically inhibiting NFK beta. This NFK beta is used for the development of your T and B cells. It also blocks neutrophil migration. So remember from term 1, remember the chemotaxis, right? The chemotaxis, remember the integrins, remember the ICAMs, right? So it blocks neutrophil migration. So you can increase peripheral neutrophil count in the blood. You can also see like decrease in eosinophil for your cortisol. And of course, it blocks histamine release from your mast cells. There's a lot of effects of cortisol. Do I need to know them? Yes. What are the big ones? What are the big ones? First, blood pressure. It maintains blood pressure. Next, suppress immune system. Reduced T and B cells in the plasma. And then it blocks neutrophil migration. Therefore, you can have neutrophilia in the blood. You can have increased peripheral neutrophil count in the blood. It also blocks histamine release for mast cells. Okay, this is good for anaphylaxis, right? It decreases eosinophil, and this is the basis for steroids as immunosuppressive drug therapy. This is my favorite. Zones of the adrenal glands. So the deeper you go, the sweeter it gets, right? That's what they say. So zona glomerulosa, fasciculata, reticularis. Look at the image on the left, the histology image. Know the histology, okay? If you have the Lippincott book of histology, the questions there, do the questions there for histology. Glomerulosa, it releases what hormone? Mineralocorticoids. Example, aldosterone. Question, what regulates your zona glomerulosa? What hormone?
ACTH.
Careful.
And
careful.
Glomerulosa. Wait, no, it's aldosterone. Oh, no, Ren. I said RAs thing. Angiotensin, I forget now.
So your zona, angiotensin 2, excellent. So angiotensin 2 for your zona glomerulosa. Angiotensin 2, what is, let's go back to
regulated, right?
What's the function of angiotensin 2?
To increase the expression of an enzyme, right?
So one word, vasoconstriction. If I have an increase in angiotensin 2, I can have vasoconstriction. Question, angiotensin 2 acts in what arteriole? The afferent or the efferent arteriole?
I think efferent.
Excellent, efferent arteriole. What does it do in the efferent arteriole? Does it dilate or does it constrict?
Constrict.
Excellent. It constricts your efferent arteriole. Why does it constrict the efferent arteriole? For what purpose does it do that?
To increase blood pressure.
Glomerular filtration.
Excellent. To increase glomerular filtration rate, right? What controls the afferent arteriole? Prostaglandin. Don't forget, prostaglandin, what does it do to the afferent arteriole? It dilates afferent arteriole. So you have two mechanisms, right? Afferent arteriole going into the glomerulus. The prostaglandin dilates the afferent. And then after the glomerulus, you have the efferent. The angiotensin 2 constricts the efferent arteriole. And they're going to give you questions like, okay, if you have an NSAID, what happens to the renal plasma flow? What happens to the GFR? If you have an ACE inhibitor, lisinopril, captopril, ACE inhibitors, what happens to the RBF and plasma, renal plasma flow and the GFR? So please integrate from term 1, integrate materials, okay? So that's zona glomerulosa. So it released mineralocorticoids, specifically the aldosterone. What regulates the production of mineralocorticoids? Angiotensin 2. Now let's go to zona fasciculata, zona reticularis. The fasciculata, it releases glucocorticoids, specifically cortisol. Reticularis, it is released by androgens, right? What hormone regulates your zona fasciculata and reticularis? Someone said it a while ago.
ACTH.
Excellent. ACTH. And don't forget the adrenal medulla. It produces stress hormone, specifically epinephrine, norepinephrine. What's the, let me see, amino acid precursor of your epinephrine and norepinephrine? Amino acid. What's the amino acid precursor?
Phenylalanine.
Excellent.
Is required for epinephrine.
Don't forget the pathway, phenylalanine to tyrosine, tyrosine to L-DOPA, L-DOPA to dopamine, dopamine to norepinephrine, norepinephrine to epinephrine. I won't bother you about the pathway and the enzymes and the cofactors, but for now, just remember that. So the precursor molecule is phenylalanine. This is the dreaded congenital adrenal hyperplasia, right? So you have 17, 21, 11. Okay, how can I explain this one? There are two parameters, right? Think about blood pressure and if the patient has ambiguous genitalia, right? So if the patient has, for example, how can I explain this one? So you have two numbers here, right? 17, 21, 11, right? You have two parts. You have the tens place and the ones, right? Do we all agree?
Yeah.
Yes, right? So on the, so you have the tens and the ones. On the ones place, think of that as ambiguous genitalia. On the tens, think about that as blood pressure. Okay, so when there's an increased blood pressure or hypertension, put 1 in the tens place. Put 1 there. Okay, if there's an ambiguous genitalia, put 1 on the ones place. That's how I that's the, what they call this one, like a technique on how to differentiate them. Okay, to make it clearer, right? What if the patient has hypertension? You have an increase in blood pressure, right? But you don't have ambiguous genitalia. What is the congenital adrenal deficiency that you can have? It's 17, 21.
17.
17, excellent. Because you have hypertension, so you put 1 in the tens place. And then for ambiguous genitalia, since you don't have any, then there's no 1. So it can only be 17. That's a technique, okay? How about, let's say, the patient doesn't have hypertension, normotensive. You have a normotensive patient, but the patient has ambiguous genitalia. What kind of CAH does the patient have? You don't have hypertension, but you have ambiguous genitalia.
21.
Could it be either 21 or 11?
It's 21. 11 is you have both hypertension and ambiguous genitalia.
Right.
Right? Okay, I know this is, what time is it? So if you have questions, you can DM me or post on the Facebook page, okay? So this is very, very high yield. If you have the first aid book, if you have the first aid 2020, they have the technique written down there, okay? Or go to YouTube and check for the technique of identifying congenital adrenal hyperplasia disorders, okay? Cushing syndrome, do I need to know this? Yes, it's high yield. What are the effects? Think about increase in cortisol or hypercortisolism, hypertension, hyperglycemia, diabetes. You have immune suppression. So look at the image here on the right, on the upper right. What happens? You have stimulation of adipocytes. You have central obesity. You have a moon face. They love that one. You also have a buffalo hump, a fat mound at the base of the neck. When I say Cushing's, you say hypercortisolism, you say moon phase, you say buffalo hump, you say progressive central obesity. What's the diagnosis? This will be much more explained to you in term 4, but for now, low dose dexamethasone suppression test, right? So you administer this one at bedtime. Normally it suppresses the ACTH. The cortisol should be low. And then in the morning, you check the blood. The cortisol remains high. What's the diagnosis? Cushing's syndrome. Let's summarize. Low dose dexamethasone test. You give it at bedtime to the patient. You expect a cortisol level to be low in the morning. You check the blood in the morning. And if the cortisol remains high, what's the diagnosis? Cushing's syndrome. Symptoms of adrenal insufficiency, the opposite of your Cushing's. You have loss of everything. You have hypertrophy of your, I'm sorry, not hypertrophy. You have atrophy of your adrenal cortex. You have a loss of cortisol. So everything is down, right? You can have postural hypotension. You have abdominal pain. You have diarrhea. You can have loss of aldosterone. If aldosterone is lost, no sodium reabsorption. So what happens? Hyperkalemia. And what else happens? H+ retention. So you can have acidosis. What happens to the sodium? Sodium, you have increased sodium loss in the urine. That's why you can have hypovolemia. Look at this one. This is famous president, JFK, right? He has Addison's disease. He concealed it to the public during his presidential run. So this is Addison's hyperpigmentation. You can have generalized hyperpigmentation. Why do you have hyperpigmentation in Addison's? Why? What's the mechanism of hyperpigmentation?
The melanocorticoid is formed the ACTH, something like that.
Mm-hmm. And?
Isn't the melanin alpha melano?
So remember POMC, pro-opiomelanocortin. Your pro-opiomelanocortin, you can have your melanin from there. You can also have a derivative of that is melanin. A derivative is ACTH. Another derivative you're going to learn in term 4, mu, your opioid receptor. So pro-opiomelanocortin. So here you have generalized hyperpigmentation. Most obvious where? Sun-exposed areas. So if you've seen pictures of Kennedy, he usually wears like a long sleeve, long clothes, right? He doesn't expose parts of his skin. Usually can be seen in face, neck, and back of hands. But when you can see, he has this tan, right? He has this uncanny tan, which is actually a symptom of Addison's, hyperpigmentation. Classic scenario, darkening of the skin. You can have GI symptoms, nausea and pain. Why do we have hyperpigmentation in Addison's? Because of a POMC, decrease in POMC. Why? What are the derivatives of POMC? Pro-opiomelanocortin. You can have ACTH, you can have melanin, and you can have your mu opioid receptors. What are the classic scenario of someone who has Addison's disease? GI symptoms, nausea and pain. And don't forget, uncanny tan. You have a darkening of your skin. Pheochromocytoma. What is this? There's something wrong. There's a tumor in your adrenal medulla. What are the presentation? Episodic symptoms, hypertension, high yield hypertension. You can have headaches. You can have palpitations. And then you can have sweating. What is a diagnostic tool to know if someone has pheochromocytoma? What can you check?
The urine.
The urine. What can you see in the urine?
VMA.
Excellent. Your vanillyl mandelic acid. What else? You have an increase in metanephrine, right? Your metanephrines. Let's go back to term 1. Wow. How are you going to treat someone who has pheochromocytoma?
Phenoxybenzoamine.
Phenoxy?
Phenoxy, yeah.
Excellent. No, you're good. So phenoxybenzoamine. Contrast this one with what? Another agent that you can use.
Beta blockers.
Careful. I'm talking about alpha.
Phentolamine.
Excellent. So I'm talking about alpha-2 antagonist, right? So you have your phenoxybenzamine and phentolamine. What's the difference between the two? Which one should you give first?
I think phentolamine.
Careful, careful.
Phentolamine is pre-op, right?
Careful.
No? Okay.
So you give phenoxybenzamine. Why phenoxybenzamine first? Remember, it is
alpha before beta to avoid hypertensive crisis.
Exactly. So remember, it's an irreversible inhibitor. Okay, irreversible inhibitor. What happens to the Km and Vmax for an irreversible inhibitor? Same Km, decrease in Vmax, right? So learn to integrate materials. I'm telling you, learn to integrate materials right now, because at the end of the term, you have BSCE, okay? So you give phenoxybenzamine first, and then for episodic treatment, you give phentolamine. When I say pheochromocytoma, you say hypertension, headaches, palpitations, sweating, right? What's the treatment? You give phenoxybenzamine first before surgery, and after surgery, you can give your phentolamine, your alpha-2 antagonist. Voila, here it is from dopamine. You have MAO and COMT. What are those MAO and COMT? They degrade your dopamine to what? To HVA, so monoamine oxidase, and catechol O methyl transferase. Let's go back to term 1. Someone who's on MAO inhibitor, he goes out partying, he drank wine, he eat cheese. What do you think might happen to that patient? Hello?
I'm sorry, could you repeat that again? I couldn't hear.
Okay, so a patient who's on MAO inhibitors, like phenelzine, for example, he goes out partying, drinking red wine, and eating cheese. What do you think might happen to that patient?
Oh, that has to do with tyramine in the cheese and the wine.
Excellent. What do you call that?
Is it a hypertensive crisis?
Very good, very good. So you can have hypertensive crisis in a patient. So you advise your patient, if they're on a MAO inhibitor, not to drink red wine or not to eat cheese, because they're going to have a hypertensive crisis. What's the high yield point here? Dopamine is broken down by 2 enzymes. What are they? MAO, monoamine oxidase, and catechol O methyltransferase, and COMT to what? Homovenilic acid. Now let's talk about the pancreas. Pancreatic islets, islets of Langerhans. Alpha cells, glucagon. Alpha cells, glucagon. Beta cells, insulin. Delta cells, somatostatin. Look at the image. Look at the histology on the lower right side. Where are the beta cells? They are located centrally. They are centrally located, and the glucagon and the somatostatin, they are interspersed throughout the pancreatic islets. High yield point, alpha cells, glucagon, beta cells, insulin, delta cells, somatostatin. Where can I find beta cells? Centrally located. So the big thing here is this. This is your beta cells. Reproductive hormones. They are steroid hormones. So they act on the intracellular receptor. They come from your cholesterol. They are poorly soluble in the plasma. They are carried by sex hormone binding globulins. And as I've said, they cross lipid bilayer and they bind to intracellular receptors. Regulation, hypothalamus, GnRH. Then it releases GnRH. It acts on the pituitary to FSH and LH, right? Which acts on the testes and ovaries to secrete androgens or estrogens. And remember, an increase in androgens and estrogens is downstream thing. It will gonna induce a negative feedback mechanism to both the pituitary and the hypothalamus. Male reproductive system, don't forget, hypothalamus secretes GnRH from the pituitary. anterior pituitary to secrete LH and FSH. The LH will gonna induce the Leydig cells to produce testosterone. The increase in testosterone will gonna have a negative feedback to the pituitary and the hypothalamus to decrease the production of GnRH and LH. So again, what's the point? And when the downstream products are increased, it always produces a negative feedback to the hypothalamus and to the pituitary. To what? To decrease the release of your releasing hormone, right? From the hypothalamus and the hormones from your pituitary. Always. Negative, think about negative feedback. Again, we talk about dihydrotestosterone, 5-alpha reductase, right? Which converts your testosterone to a much more potent, which is dihydrotestosterone. Remember, DHT has increased potency, right? It's much more stable, okay? Estrogen, don't forget also that testosterone can be converted to estradiol. This occurs in adipose tissue and Leydig cells. High yield, what's the enzyme? Aromatase. Aromatase is the enzyme that converts your testosterone to estradiol. Where? Adipose tissue and your Leydig cells. What are the effects of testosterone? As I've said, development of your external genitalia, specifically your penis, scrotum, and prostate, via your dihydrotestosterone. It also induces the development of your mesonephric duct, your internal genitalia. What are they? Seminal vesicles, your epididymis, and then your vas deferens. Sertoli cells, they support and nourish the developing spermatozoa. They regulate spermatogenesis, as I've said before, and we talk about spermatogenesis, about blood testis barrier. Inhibin B, don't forget also Sertoli cells, inhibin B, it inhibits FSH. Okay, Sertoli cells also secrete inhibin B. So they also secrete androgen binding protein and anti-Mullerian hormone. When I say Sertoli cells, they secrete what? They secrete inhibin B, they secrete androgen binding protein, and they produce anti-Mullerian hormone. That's your Sertoli cells. How about your female reproductive system? Don't forget, from the granulosa cells, they produce your estradiol, your estrogen, which have a negative feedback to your pituitary and your hypothalamus. What are the effects of estrogen? The growth of the follicle during the follicular phase of the ovarian cycle, right? It also raises your HDL, and it lowers your LDL. In puberty, think secondary sexual characteristics for estrogen. So you have breast enlargement, pigmentation of areola, and female body habitus. For progesterone, this is synthesized by your corpus luteum. What happens to the corpus luteum if there is no pregnancy?
It involutes.
It involutes, exactly. And what do you call that?
It becomes a corpus albicans.
Exactly. Don't forget that one. Corpus albicans. But if there's the progesterone is synthesized first by your corpus luteum, and then afterwards by your placenta, right? So this is bound to albumin. The main target is your uterus, cervix, and your vagina. The hormone of pregnancy, don't forget, it's always progesterone. It thickens the cervical mucus. When you think progesterone, think about maintenance of pregnancy. Progesterone, think about maintenance of pregnancy. You want that pregnancy to carry on. So it is up. Progesterone is increased during the secretory phase of the uterine cycle. It thickens the cervical mucus. It prevents uterine contractions. Remember, you need to maintain the pregnancy. It raises the body temperature. It also inhibits negative feedback mechanism. It inhibits LH and FSH release. And we talk about this, the menstrual cycle. What causes ovulation?
Surge, LH surge.
What hormone is increased during the follicular phase?
FSH.
FSH, right? And how about in the endometrium? Follicular phase, think about estrogen, right? Luteal phase, think about progesterone, think about LH, right? Maintenance of pregnancy. Okay, those are high yield. Please know the menstrual cycle and the ovarian cycle. We talked about what happens in the uterus here during the proliferative phase. During the proliferative phase, right, you have an increase in estrogen, the development of the decidua, and then the secretory phase, progesterone, increase in progesterone, which induces the glandular nature of your decidua. You have the formation of your spiral arteries. Please make sure you know the histological image between the proliferative phase of the uterine cycle and the secretory. They might give you an image, okay, a histological image. So when you see spiral arteries, when you see formation of glands, where can you see that? Secretory phase. Pituitary gland connected to hypothalamus. It connects to median eminence. Your posterior embryological origin of this neural ectoderm, right? So remember VSOP, my mnemonic, VSOP for posterior pituitary gland. V for your vasopressin or your antidiuretic hormone. It is secreted by your supraoptic, right? VS, and then OP, oxytocin via your paraventricular. Remember, they are made in the hypothalamus. However, they are being stored in your posterior pituitary. How does these hormones travel from the hypothalamus to the posterior pituitary to be stored? What do you call that transport protein? High yield.
Neurophysin.
Excellent, neurophysin. So they are the ones that's connecting your paraventricular and supraoptic nuclei from the thalamus to the posterior pituitary. Oxytocin, what's the function?
Milk ejection.
Excellent. You milk let down reflex for your oxytocin. Is there any other function of oxytocin?
Orgasms.
Bonding.
Let's talk about birth. Exactly.
Relaxing of ligament.
So yeah, yeah. So you have contractions, right? Contractions of your uterus. Okay, supraoptic antidiuretic hormone. What part of the nephron? What part of the nephron does your ADH act on?
Collecting ducts?
Collecting duct.
Yeah. What receptors?
V2.
V2 receptors. Do you have? This is from term 1. Yes, you have V1 receptors. Where can you find your V1 receptors?
Blood vessels.
Excellent. Specifically what? Arteries, right? Remember your arteries?
Yeah, sorry.
Receptors, right? So ADH, V2 receptors. Where? Collecting ducts. So what happens if I have ADH and I have the V2 receptors? So they interact together and what happens? Someone said it a while ago.
It brings aquaporins to the
excellent. Increases expression of your aquaporins. And then what happens? You have
water reabsorption.
Water reabsorption, exactly. Do you reabsorb solute in ADH via ADH? No, you only reabsorb water. When you're thinking of ADH, I want you to think of another hormone that counteracts ADH. What is that? Think about atrial natriuretic peptide. Think about ANP and think about your BNP, okay? Which counteracts your ADH. They induce what? Natriuresis, okay? So we'll talk about this one, anterior pituitary, Rathke's pouch. What are the hormones from your anterior pituitary? Flat pig, go.
FSH, LH, ACTH, TSH, prolactin,
growth, GH, growth hormone. Basophils. What are the basophils? B flat, go.
FSH, LH, ACTH, TSH.
Excellent. So that's your B flat. ACTH, it induces what? It induces production of what?
Cortisol.
And what else? Androgens. Remember from your zona reticulata, right? So your ACTH, it acts on your zona fasciculata and zona reticularis to increase the production of your glucocorticoids, specifically cortisol, and by your androgens, right? How about TSH? TSH, it goes to where? Thyroid gland to increase production of T3 and T4. You have the gonadotropes, your GnRH, right, from the hypothalamus to increase production of your LH and FSH. You have the growth hormone, and then you have the prolactin. So prolactin is high yield, okay? Prolactin, it's under inhibitory control from the hypothalamus. So what regulates prolactin? Dopamine, right? Dopamine. So in the vignette, if they say that this patient has, for example, prolactinemia, she's not pregnant, but she's producing milk. And then you've done an MRI, and there is something in the suprasellar chiasm of the brain, right? So this is a prolactinoma. So what are you going to give in someone who has prolactinoma?
Bromocriptine.
Bromocriptine. They are dopamine agonists. So you have your cabergoline and you have your bromocriptine, your dopamine agonist, right? So don't forget that one. Prolactin under inhibitory control from the thalamus. Under what? Under the control of your dopamine. If someone has prolactinoma, an increased production of prolactin, you need some dopamine agonist to inhibit that prolactin. You give cabergoline and bromocriptine. Hyperprolactinemia in women, it can induce amenorrhea and galactorrhea. In men, you can have decreased libido, impotence, infertility, and gynecomastia. Sheehan syndrome. When I say Sheehan syndrome, think a vascular necrosis of the pituitary gland. Okay? Sheehan syndrome, avascular necrosis of the pituitary gland. What happens in Sheehan syndrome? Anyone? Give me the physiology.
Oh, I was going to say there's postpartum hemorrhage, and because the pituitary gland increased during pregnancy, but it still had the same blood supply, it becomes ischemic.
Exactly. So the loss of the blood, the loss of a lot of blood during childbirth induces formation of the hypovolemic shock. And remember, in hypovolemic shock, what happens to capillary output? Let's go back to term 1. What happens to cardiac output? Hypovolemic. This is physiology. Go ahead.
Well, it's going to try to, it decreases initially, but it's going to try to compensate.
Exactly. So how does it compensate? You have decreased cardiac output. You have decrease in post-capillary wedge pressure. Remember the PCWP, which checks the pressure on your left atrium, right? It decreases, and it compensates via what? Increase in your total peripheral resistance. But remember, as you've said, like the pituitary has limited blood supply only via the hypophyseal system. It has blood supply. So if you have hypovolemic shock, it can be a site of infarction from your hypovolemic shock. It's enlarged, but it has a limited blood supply, okay? So Sheehan syndrome, a vascular necrosis of the pituitary gland. What happens? There's a postpartum hemorrhage, which causes hypovolemic shock. This hypovolemic shock induces what? Failure to lactate, okay? Can present a shock after delivery and also can see failure to lactate. Growth hormone, think about anabolism. You're building up. Think about anabolic steroids, right? Growth hormone. You're growing. Think about that. It stimulates by GHR8, growth hormone releasing hormone, exercise and sleep, inhibited by glucose somatostatin high yield and IGF-1. This is the mechanism. Growth hormone, GHRH, increases that. Somatostatin, glucose, and IGF-1 decreases the growth hormone. When I say growth hormone, you say anabolic reactions, meaning raises blood sugar, increases lipolysis. You're growing, right? You have linear growth. You have increase in your lean muscle mass. What if you have more growth hormone? You can have acromegaly. Acromegaly, look at the picture here. They have enlarged jaw. You can have coarse facial features, enlargement of the nose and the frontal bone. We talk about this one, the POMC, which is a precursor of ACTH. It is also a precursor of melanocyte, stimulating hormone. It causes hyperpigmentation in your Cushing's disease. High yield POMC, what are the derivatives? You have MSH, right? You have ACTH, and you have your mu opioid receptors. Oxytocin, produced in paraventricular nuclei, causes milk letdown, and also contraction of the uterus. What if you want to induce labor? What are you going to give to the patient? You give Pitocin, which is a synthetic oxytocin. Also, if the patient has postpartum uterine bleeding, you want to stop that bleeding, give Pitocin. Parathyroid hormone. What are the effects of PTH? Increase calcium. When I say parathyroid hormone, you say increase plasma calcium. How does it do that? Let's go back to term 1. Where in the nephron does it act on? Anyone?
Is this one also the collecting ducts?
So the parathyroid hormone, it acts on the nephron, right? What part of the nephron that does it act on? Two parts of the nephron. Go ahead.
And the proximal? Is it the proximal and the DCT?
Excellent. Proximal convoluted and DCT. What does it do on the proximal convoluted tubule?
I think it increases calcium reabsorption.
Careful.
So is it the phosphate secretion?
Phosphate excretion, exactly. So it increases phosphate excretion. You need to waste the phosphate. In the DCT, you absorb the calcium. So PTH acts on the kidney, right? The kidney. What enzyme does it increase in the kidney for the production of your calcitriol? Remember the calcidiol and calcitriol?
Alpha-1.
So 1-alpha hydroxylase. Okay, to make it clearer, let's go vitamin D synthesis from term 1 to make this clearer. Okay, so we have cholecalciferol, right? Cholecalciferol from the diet, for example. Or 7-dehydrocholesterol, you have sunlight there to make cholecalciferol. And then pre-vitamin D3 to calcidiol. Where? Where is that? What organ?
In the liver.
In the liver. What enzyme converts it to calcidiol, pre-vitamin D3 to calcidiol?
25-alpha hydroxylase.
So 25-hydroxylase, okay? 25-hydroxylase. Your calcidiol, we're gonna go to the kidney, right? What enzyme converts calcidiol to calcitriol or 1,25-dehydrocholecalciferol?
1-alpha hydroxylase.
1-alpha hydroxylase. What's the function of this calcitriol now? The main function?
To go to the gut to increase calcium reabsorption.
Specifically where? In the gut. Don't forget, in the GI, in the intestine. It increases calcium reabsorption in the gut. It also has other functions, specifically increased resorption in your bone, right? So we're clear about vitamin D.
Next time.
Okay, so parathyroid hormone, Let's summarize. It acts on the proximal convoluted tubule to increase phosphate excretion. You want to waste that phosphate. And it acts on the distal convoluted tubule of the nephron to increase reabsorption of your calcium. When I say PTH, what enzyme, what hormone opposes PTH? Calcitonin. Calcitonin, it opposes your PTH. Primary hyperparathyroidism, you have an increase in PTH, which increases your serum calcium level, which decreases your phosphate plasma level. So what are the symptoms? Stones, bones, groans, and psychiatric overtones. When I say primary hyperparathyroidism, you say stones, bones, groans, psychiatric overtones. You can also have some recurrent kidney stones, of course, and most commonly seen in your malignancy. Okay. Secondary hyperparathyroidism. You have an increase in PTH. However, you have a low serum calcium. So it doesn't have the desired effect, right? So why does this happen? This happens due to renal osteodystrophy. Think renal osteodystrophy. So you can have bone pain, you can have fractures, right? It can also lead to osteitis fibrosa cystica. You're going to learn this one in term 4. Osteitis fibrosa cystica, wherein the muscle can become bone. The muscle can become bone. So secondary hyperparathyroidism, you have an increased PTH. However, you have low serum calcium. Let's contrast primary hyperparathyroidism. What can we see in the blood? Increase in PTH, increase in serum calcium, right? Contrast this one with secondary hyperparathyroidism. What can we see in the blood? Increased PTH, but decrease serum calcium. So you don't have the desired effect of your PTH, commonly seen in renal osteodystrophy. Specifically, those patients end-stage renal disease, we're going to learn in term 4. Now, hypocalcemia. So you have a low calcium levels. What can we see? Neuromuscular irritability, tingling of fingers, toes, intermittent spasms. High yield for your OSCE. Don't forget tetany, Trousseau's sign. So if they say, how can you test for hypocalcemia? You can either do 2 things for OSCE. Chvostek sign, you tap on the cheek and you see contraction. You are tapping the facial nerve, actually. When you're tapping the facial nerve, if you see contraction, that's hypocalcemia. Or inflate a blood pressure cuff. If you inflate the blood pressure cuff high enough, you can see carpopedal spasm or hand spasm. That's a Trousseau sign. Okay, so these are the signs for your hypocalcemia: Trousseau sign and Chvostek sign. Know them for your OSCE and for your exam. All right, I think that's it. You have some MCQs. So if you have any questions, you can DM or post on the Facebook page. It's been a pleasure talking to you, reviewing with you, studying with you together. Good luck on your exam. Okay?
Thank
Thank you so much.
Thank you so much. Good luck studying.
Thank you so much, Nick. Thank you.
Did you take your step 1 yet?